So this will be a lecture on Brugada syndrome. So it's a relatively more rare type of cardiac syndrome that we would see on step one and step two. I have seen it tested on both, and I think it's a really important one to know if you're in the emergency room or you're on internal med. And it classically it shows up on step exams, so that's why I'm going over it. I also think it's a good way for me to start getting into EKGs instead of doing like a few big EKG lectures. I'll kind of hit high points as we go so we can break it down into more like manageable pieces and we can do spaced repetition that way. Um, so we'll discuss the pathophys, presentation, and management of Brugada. We'll dive into the treatment and then we'll do a putting it all together. So our case to consider, I put this on Instagram. We have a 24-year-old man. He recently immigrated from Vietnam. He presents to the ED after collapsing while playing basketball. Nothing like this has ever happened before. His EKG is shown. Which of the following pharmacotherapies is next best step in management? Should we do an aspirin plus a P2Y12 inhibitor, quinidine, metoprolol, or amiodarone? Here's his EKG. We've got leads V1, V2, and V3 shown. So pause your screen, think about it, and then we'll discuss. All right, so before discussing, I think it's important that we kind of get some like terminology out of the way. So just real briefly, when we're thinking about the QRS and the J point in the EKG, because that's really what we're going to be focusing on for this lecture, we kind of have to understand what these are. So the Q wave is the first negative deflection before any positive deflection after the P wave. So we get the P wave, and then it's the first negative deflection. So if we look at V1, here's my P wave, which indicates atrial depolarization. And then here would be my Q wave, right? The first negative deflection after the P wave. Okay. R wave is the first positive deflection after the P wave. So again, if we go back, P wave, first negative deflection, Q wave, and then here's my R wave going back up, positive deflection. The S wave is the first negative deflection after the R wave. So again, P wave, atrial depolarization. Here comes the Q negative. Here comes the R. And then this little bit right here would be considered our S wave. Okay. And then the J point is really the junction between the end of the QRS and the start of the ST segment. So here's my T wave. Here's my S. So this little guy right here is my J point. Okay. The J point is super duper important because that space between my QRS and the T wave, that J point, that's what I use to measure, do I have ST segment elevation or depression, right? And so when I think about ST segment elevation or depression, we look at my isoelectric line. So you see right before the P wave here, we've got that straight line, right? So that's like the baseline of my cardiac electrophysiology, okay? Right after the T wave, we kind of hit right back on that baseline, my normal baseline of how the cardiac electrophysiology is working, okay? When the heart is not, when we don't have these electrical signals moving through. So this is what we call our isoelectric line, okay? I look at my J point, and I compare my J point is all the way up at this solid line here. So it actually worked out pretty well. And my isoelectric line is, let's say it's 1, 2, about 3 or 2.5, 3 little boxes below. Okay. And each little box represents 1 millimeter. Okay. So if the J point is 2 millimeters or more, that's usually what we consider an ST segment elevation. It gets a little more nuanced than that. But for step one and step two, I want you to think J point higher than 2 millimeters above that isoelectric line. So here's my isoelectric line. If that J point is above 2.5 or 2 millimeters, then we've got ourselves some ST segment elevation. We usually like to see that in 2 contiguous leads, meaning V1 followed by V2, which we do see here. Okay, so we might be thinking STEMI here. Okay. Obviously, this is case on Brugada syndrome because that's what this lecture's on. So this probably isn't a STEMI, but we'll discuss there. So really, high yield takeaway, right? QR or the Q is the first negative deflection after the P wave. The R is the first positive deflection after the P wave. And the S is then the first negative deflection after the R wave. And then the J point is that transition, kind of where we get more of a flat area in between the QRS and the T wave, okay? I use that J point, and if it's 2 millimeters above the isoelectric line, that's considered ST elevation. 2 millimeters below, that's considered ST depression. I'll do a whole lecture on ST depression at some point too. All right. So if we were thinking this was STEMI, aspirin plus a P2Y12 inhibitor would probably be a great option, right? We'll do a whole lecture on STEMI coming up, but that would be considered standard of care for STEMI or NSTEMI or acute coronary syndrome, right? we'd want to get the patient to do percutaneous coronary intervention within the first 90 minutes of presentation if we can, right? So revascularization. When I think about metoprolol, metoprolol is a class 2 antiarrhythmic, great option for AFib, right? It's a great option for rate control and AFib. This patient's not an AFib, okay? I didn't even show you enough of a rhythm strip for you to pick to think about AFib, right? I only gave you one beat, one atrial and one ventricular contraction from V1, V2, V3, so we can't even see what's the underlying rhythm here. Amiodarone is classic or is technically a class 3 antiarrhythmic, which are potassium channel blockers, but amiodarone does have capabilities of class 1, 2, and 4 as well, not used in the treatment of Brugada syndrome. Quinidine is used in the treatment of Brugada syndrome. So the American College of Cardiology and the American Heart Association and the Heart Rhythm Society recommend quinidine for patients with Brugada syndrome who have recurrent ventricular arrhythmias and are not candidates for ICD placement, okay? So ICD placement is the gold standard. That is going to be the definitive treatment for Brugada syndrome, and we'll talk about why. But basically, Brugada syndrome is going to lead to an abnormal electrical signals throughout your heart, which can lead to early repolarization. And when we get too early of repolarization, we get too many beats on top of each other, and it can lead to ventricular fibrillation, where my ventricles just go boop, 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 boop. And when that happens, we basically don't get any cardiac output, and the patient can go into sudden cardiac death, okay? That's how these patients die. So basically what we're going to do is we're going to try to get this patient an ICD. If they're not a candidate for ICD, or for some reason they don't want ICD placement, or we need to do pharmacological therapy for X, Y, or Z reason, quinidine is the gold standard. Now, quinidine is a class 1 antiarrhythmic, okay? And we'll talk a little bit more about how quinidine works in a second with regards to Brugada syndrome. But again, this is our classic Brugada type pattern, and we're going to break down more why this is Brugada and not a STEMI in a little bit. But really, I want you to take a special look at V2. Look at this nice coved ST segment right here. Look how it looks like a little cove. It's almost like a triangle. It's like a nice 45-degree angle. That's going to come into play in a little bit, all right? So what is Brugada syndrome? Brugada syndrome is a genetic channelopathy which leads to the increased risk of sudden cardiac death. And we're going to talk about which type of channelopathy on the next slide. I classically think about it as an autosomal dominant disorder, variable penetrance, and it's classically in Southeast Asian men. So we had our Vietnam patient, right? It often presents in the 30s and 40s, but it can present earlier. And there's a higher incidence during sleep, fever, or exertion. So back, before we even knew what Brugada syndrome was, there were case reports of men, like younger Southeast Asian men, who would just die unexpectedly in their sleep. And that kind of led to the discovery of this Brugada syndrome. But any kind of thing that can lead to the overexertion of the patient can also lead to sudden cardiac death. So it almost kind of seems like HOCM or maybe Wolff-Parkinson-White or an other kind of thing like long QT syndrome. So there's so many things you need to consider, okay? But when I think about a patient, especially like a younger patient who has this syncopal episode, right? I need to decide, first off, is this syncope or is this seizure, right? If it's syncope, they're going to have a loss, it really depends on the type of syncope. Let's take a step back first, right? So if it's like vasovagal is the most common cause of syncope, they could have tunneling of vision. They could feel really hot. They could feel flushed. They could have sweating, right? They're going to feel like an impending sense of doom, and then they might collapse, okay? Cardiogenic syncope, they might feel palpitations, or they might not feel anything at all if it's a ventricular syncopal episode. And then there's neurogenic causes of syncope as well. Syncope will be a lecture for like its own on another day. But really, I can think about syncope versus seizure. In a patient with syncope, it's going to be relatively quick. They're going to come out of their syncopal episode, and they're going to have a pretty good idea of what's going on, okay? They're not going to be totally confused. They might be confused like immediately when they see like 20 people standing over them to see what's going on. But they'll be pretty with it. They'll be able to tell you what's going on. Whereas like in a seizure, right, a patient with a seizure disorder, they're going to have their whole post-ictal state, right? And so post-ictal state, the patient might be confused for quite a bit. They could have what's called Todd's paralysis, where part of their body is still paralyzed post-seizure, and that tends to go away with a little bit of time. They could have urinary incontinence, and they could bite their tongue laceration. So those are all things I think about. So when I think about a patient who has a syncopal episode, right, I need to first decide, is this syncope? And if it's syncope, was this due to, a neurocardiogenic, a cardiogenic, a hypovolemic, or was this like something else, right? We need to decide that. So right away, we're probably going to get an EKG on all these patients, okay? And that will kind of lead us into Brugada. Or if it's not syncope, what would lead me into a seizure, right? Was the patient confused? Did they have urinary continence, right? What were they doing when they had their loss of consciousness, right? What did they look like? Were they doing their tonic-clonic contractions, right? So when I think about syncope, right, patient presents to the ED, we're going to get some sort of EKG, and that's kind of how we would kind of dive deeper into Brugada syndrome. So what is the pathophysiology? It's this SCN5A mutation, which leads to a decrease in the inward sodium current. So, right, we called it a channelopathy, and now we can get a little more specific. It's a sodium channelopathy. It's a problem with the sodium channels, which leads to decrease inward sodium current. It affects my right ventricular outflow tract, and that leads to transmural dispersion of my repolarization. And it leads to this phase 2 reentry and polymorphic ventricular tachycardia and ventricular fibrillation. And I already told you things that can set it off are fever, vagal tone, sodium channel blockers that block the sodium channel and make it even worse, and exertion. So again, really, if we're trying to be specific, your attending asks you, or you're trying to think about the pathophys to make this make sense. Brugada syndrome is a sodium channelopathy. It leads to the decreased inward sodium current flow. It classically affects the right ventricular outflow tract, and it's classically in Southeast Asian men, usually between anywhere 20 to 50 years old, okay? And when I look, right, we looked at leads V1, V2, and V3. And where are leads 1, V2, and V3 on my when I do my EKG, right? They're looking at the anterior and septal part of my chest, right? Of the anterior and septal part of my heart, right? And what makes up the vast majority of my anterior and septal part of my heart is my right ventricle, right? That's why this should start making sense to you. Oh, I need to look at V1, V2, V3 if I'm thinking about Brugada syndrome, right? Because it classically impacts the right ventricular outflow tract, okay? So what are the EKG patterns? Again, I told you type 1 is really the only one we're going to talk about, but we see those coved ST segment elevations greater than 2 millimeters in V1 through V3, plus the inverted T wave. So inverted T waves can be non-specific. Inverted T waves can also tell me there's strain going on or some sort of ischemia, but classically to diagnose type 1 Brugada, we see in V1 through V3, especially V1, V2, we see these nice coved ST segment elevations followed immediately by an inverted T wave, okay? Classic. The type 2 and type 3, again, not going to be diagnostic. In type 2, we could see saddleback, so it looks almost like you could hop on and like take a ride on the horse. If you think about the ST segment, it looks like a saddle. And type 3 is less than 2 millimeter segment ST elevation, variable shape. Only type 1 is diagnostic, so that's the only one we're talking about. Coved ST segment elevation greater than 2 millimeters or 2 little boxes in V1 through V3 plus inverted T waves. So how do we make that diagnosis as clinical plus EKG being type 1? We can do we can provoke the Brugada syndrome, right? So I could give the patient some nice strong sodium channel blockers that will make their Brugada a little bit worse. Obviously, we only do this in the hands of a really good cardiologist or electrophysiologist who knows what they're doing. So we can give them flecainide or percanamide to kind of push them into type 1 Brugada syndrome. We need to rule out mimics because sometimes Brugada syndrome can look like right bundle branch block. It can look like early repolarization. It can look like ARVC, pericarditis, and ischemia. Again, these will all be lectures for another day. So if you have no idea what these are, don't worry about it. This is solely a lecture on Brugada syndrome. A family history of sudden cardiac death or Brugada can be very helpful, obviously, right? Helps me narrow down my differential. If I know that, oh, they had an uncle that died of a sudden cardiac death, when he was 30 years old, that can help me. So how does it present? Right, it could be asymptomatic and we could just find the EKG on a, regular screening visit. They could have syncopal episode, right, especially during rest or exertion. They could have sudden cardiac arrest, and it's often unmasked. We've talked about this. Fever, sodium channel blockers, some sort of electrolyte shifts, heavy metals, alcohol, and vagal tone. All right. This is the really important part because this was talked about in my question. How do we manage it per the American College of Cardiology and the AHA? For symptomatic Brugada syndrome, ICD. Okay, we're going to put an ICD to anytime that patient starts to get into VFib, we shock them out of it, right? We defibrillate them out of it. If they're asymptomatic, we can consider an ICD. If they're asymptomatic plus a drug-induced type 1 observation or an EP referral, pharmacological, we can treat with quinidine, which is an ETO blocker, right? We'll talk about what ETO is in a second. Fever, we're going to try to aggressively treat that fever because if we keep letting the fever go, it could push them into a full-blown Brugada and then they could have sudden cardiac death, right? Really what I want you to get out of this, treatment for USMLE step 1, step 2, and real life, we're thinking about ICD and we're thinking about quinidine, okay? ICD is definitive. Quinidine can kind of bridge us over. All right. So how does quinidine help in Brugada despite it being a sodium channel blocker, right? I literally told you sodium channel blockers like flecainide and procainamide can push the patient into further Brugada exacerbation. So why the heck would we give quinidine, right, which is a 1A antiarrhythmic, which is a sodium channel blocker? Why would we give them quinidine, right? That doesn't make sense. Let me make it make sense to you, right? So quinidine has multiple effects, right? It blocks the fast sodium current channels, right? It's a class 1A, but it's really a mild effect compared to things like flecainide, which is a class 1C. It doesn't really exacerbate Brugada in the same way, okay? It blocks what's called this ETO current, which is a transient outward potassium current. And this is really the key, okay? So in Brugada, it's the epicardium of the right ventricular outflow tract that has this exaggerated ETO current, right? And when we have this exaggerated ETO current, we flood out too much potassium and we get more of an early repolarization. So if you really look at V2, right, normally on a normal EKG, the ST segment will be kind of more flat. The T wave will take its sweet time and it'll be more of a flat pattern. We look at this V2, especially in V1, look how quick this repolarization is happening, right? It's kind of like at the snap of a fingers, we get that repolarization. That's because in Brugada syndrome, this ETO current is moving too quick because of this sodium channelopathy. All right, so it's this exaggerated ETO current that causes that spike and dome, like we see that cove T wave, and it creates that ST elevation and arrhythmia. By blocking that ETO current, right, quinidine helps to normalize the repolarization gradient, and it prevents that phase 2 reentry, which prevents VTAC and VFib. Okay, so it's also got this mild anticholinergic effect, which may reduce vaguely mediated arrhythmias. I'm going to explain this more in like layman's terms, right? Because I know that was definitely confusing. It took me a little bit to kind of wrap my head around it. But so I kind of came up with this metaphor, right? So the heart is a city with roads and traffic lights. So imagine your heart is a city and the electricity that keeps it beating is like traffic moving through roads, okay? In Brugada syndrome, one part of the city, our right ventricular outflow tract, has these weird roads with no streetlights, okay? So sometimes the cars can go too fast, they can crash, or they can drive in circles. It's like a dangerous heart rhythm, right? Because they can't see in this part of the city, right? Normally the cars go in one direction, but here they might turn around and cause traffic jams, okay? That's the heart getting confused and stopping, all right? Now quinidine is like the city planner who adds special cones and gentle curves to slow the cars down. They put up just enough lights to keep the traffic flowing safely, and they don't try to completely block the traffic. It just keeps it from kind of going crazy, okay? So instead of a car crash, we get this smooth, safe driving through the city, and the heart beats normally, okay? So again, in Brugada syndrome, it's a sodium channelopathy. The SC5NA, classically middle-aged, younger Southeast Asian men, it's due to this exaggerated ETO current that causes an over-exaggeration of the epicardium in the right ventricular outflow tract, and we just kind of keep go, and it can lead to these coved ST segment elevations that can look a lot like a STEMI. And we're going to talk about how would I tell this apart from a STEMI in a second. Really, my take-home points for you are I want you to think about Brugada in a young patient with syncope plus ST elevation in V1 and V3. The type 1 pattern is diagnostic. Quinidine is the only pharmacological therapy shown to prevent the arrhythmias because it blocks that ETO current. Fever, other sodium channel blockers, or exertion can unmask the disease. And if they're high risk, the ICD save lives. All right. I'm going to show you a normal EKG in a second, and then we'll go through Brugada. But really what I want you to think about, right? I see ST segment elevations in 2 contiguous leads on my patient, right? I see him here. And I'm like, holy shit, this is an ST segment elevation. This is STEMI. Let me call the cath lab. Let me get the cardiologist on the phone. Like, we need to move now, right? This Brugada syndrome is a very, very, very serious disease, right? But they're treated very differently, okay? I need to consider the patient history before I jump to conclusions, right? So a patient with Brugada syndrome is probably going to present to my ED, or he's going to come up on my ID ward, on my IM wards after having some sort of syncopal event, okay? He's probably not going to have chest pain, right? This isn't a ischemic process. This is a sodium channelopathy, which causes arrhythmias. So that arrhythmia can lead to syncopal episode, right? Whereas a patient with STEMI, man, they're probably going to have chest pain. They're going to have heaviness. They're going to have substernal pain. It might radiate to the jaw, might radiate to their left shoulder, down their arms, right? They're going to have probably some of the full shebang, if not the whole thing. They're going to have risk factors of atherosclerosis, smoking, diabetes, right? They're probably going to be an older individual, right? When I think about Brugada syndrome, it's usually like a relatively healthy, younger male, and especially like an Asian male, right? That's going to really key me in on the differentiation there. And then when I look at the ST segments, right, it's again the classic coved ST segments with the inverted T wave in V1, V2, V3. Okay. Again, we'll kind of see some images here. So this is how I read an EKG. When I read an EKG, I kind of look at the forest and then I look at the trees. So I look down at lead 2. Lead 2 is my rhythm strip. So lead 2 goes from my right arm to my left leg. Remember, my heart is kind of it's more off to the left side, and it kind of angles down more. And so when my sinus node up at the top right of my atrium, top part of my right atrium, shoots off, and then it kicks down to the atria, and then those kick down to the AV node. The AV node kicks down then to my bundle of His and my Purkinje fibers, and then the whole ventricle is depolarized. That all kind of goes down more towards my left foot, right? When I think about the pathway these the signals are taken, right? More down towards my left foot, more or less, right? So lead 2 is going to get the blunt of these electrical forces, right? Remember, if the electrical signal is moving towards the lead, we'll get a positive deflection. If it's moving away from the lead, we get a negative deflection. So lead 2 is a great lead to look at, right? So I look at the forest, and then I look at the trees, right? This looks like it's a regular, normal rhythm, right? I look at my rate, right? Let's see if we can find one that's kind of close to a line. This one's pretty much close to a line. We'll kind of count 1, 2, 3. It's a little more than 3 boxes. So it's a little less than 100 for your rate, right? I just think about it, 300, 150, 100. This would be 75. It's closer to 100 than 75. So maybe like 90, 95 beats per minute. So close to tachycardia, but not quite there. Then what I do is I look at my P waves. Do I have a P before every QRS, a QRS after every P? Yep. Going all the way down. I'll look at my P waves in lead 1 and AVF because those should also be up. And I see them there. They're kind of hard to see in AVF, but you can see little bumps there. So they're up in 1, 2 AVF, which I would like to see. They should be down in AVR. And I see that too. So we're like, yep, this is normal sinus rhythm. Okay. At a ventricular rate of about 90, 95. So then what I'll do is I'll look further at the P waves. There's something called P mitrale and P pulmonale. Basically in lead 2, if I see a double humped P wave, or if I see a P wave longer than 2.5 millimeters, that tells me there might be some enlargement of the left atrium, okay? I can also look in lead V1. Lead V1 classically will sometimes have a biphasic P wave, meaning look at my cursor here. The P wave goes up and then it goes down. We don't really see that here, but if I see the downward part of my P wave is really big, that's another sign that my left atrial might be enlarged. So again, kind of the 3 things I look for left atrial enlargement is the P wave being double humped in lead 2, the P wave being longer than 2.5 millimeters in lead 2, or really any P wave or in any lead. And then I look for the strong negative terminal force is what it's called in V1. So the negative part of the biphasic P wave in V1 is big. Those are all things that can key me into left atrial enlargement. Again, it's something I can comment on the EKG. I cannot make the diagnosis of left atrial enlargement. I have to get an echo, okay? Then I can look at the P waves and look at what's called P pulmonale. And so P pulmonale is when the P wave is taller than 2.5. and those can key me in on right atrial enlargement. And so again, classically, I can look at my big leads like 1, 2, 3 AVF, see if there's anything there, and I really am not seeing that here. And then it's the opposite for the V1, right? So again, the V1 has the biphasic P wave, the up and then the down. If the up part, if we have a strong positive terminal force, that can be a sign that we have right atrial enlargement, okay? Not seeing that here. So my P waves look good. Last thing I do, I look at the PR interval. The PR interval should be 3 to 5 boxes. So 0.12 to 0.2 is kind of the length there, right? If we're thinking about how big these little boxes are. Or you can call it the other way around, right? I think it's easier to think about it in milliseconds. So 120 to 200 milliseconds, right? Really, if I kind of zoom in here and I look at one of these P waves, I start kind of right before the big line and I finish well before the next big line. So one big line to one big line is going to be 200 milliseconds. So we're well within our normal PR interval here. And it looks, and as I'm looking just kind of down the line, they all look pretty consistent. So I think my PR interval is good. We don't have any first degree AV block. I have a P for every QRS. I'm not having more P's than QRSs, so I don't have any AV block here. Next thing I do is I look at my QRSs. They all look nice, neat, and narrow. So the QRS should be no longer than 3 little boxes or 120 milliseconds. To look at that, I look at where the Q starts and where the S stops, and that's kind of how I determine the QRS length. And this is definitely like maybe 2 little boxes. It's hard to see on this the way this EKG is set up, but it's definitely not more than 3. We can look at the size of the QRS complexes. If they're small, if they're less than 1 box, so less than 5 millimeters, that could be a sign of low voltage, and low voltage could be caused by something like pericardial effusion or tamponade, where there's fluid around the heart and it messes with my leads being able to see the electrical activity of the heart. Or we could look for large QRSs, right? So if my R wave is super duper tall and leads V5 and V6, so remember, if V1, V2, V3, look at my right side of my heart, V5, V6, and 1 in AVL, look at the left side of my heart. So if my R waves are really tall in V5 and V6, and my S waves are really deep in V1, that can key me in on something called left ventricular hypertrophy, okay? I'll do a whole lecture on that, but there's the really well-used criteria called the Sokolov-Lyon criteria, is when I look at the R wave in V5 or V6, and I say, hey, V5 is bigger than V6, so I'm using V5. And I count the number of small boxes, okay? Then I go look at V1, and I look at the S wave in V1, and I count the number of small boxes, okay? I take whatever the R wave was in V5 in this case, plus whatever the S wave was in V1, and I add them together. If that number is greater than 35, that's a sign of left ventricular hypertrophy based on the Sokolov-Lyon criteria, okay? There are some other ways we can calculate left ventricular hypertrophy. Too much for today's discussion. I can then look, and so I don't see any of that here, right? My R waves look perfect, okay? Then what I can do is I can look for right ventricular hypertrophy. I look in lead V1. If the R wave is equal in length to the S wave, that's something that might key me in. If the R wave is bigger than 7 little boxes in V1, that could also key me in. Those are some other things. And then I can look at the S waves in V5 and V6. And if those are bigger than 7 millimeters, that can key me in too. I then look at the R wave progression. My R wave should be relatively small in V1, V2, and slowly get bigger as we move through. So V1, good, good. It's getting bigger, it's getting bigger. They actually get a little bit smaller in V5 and V6. I'm not super worried about that. But really, my R waves should be small and move up as I go from V1 to V5 and V6. And my S waves should do the opposite, okay? My S waves should be really big in V1 and V2, and they should get smaller. And if we look, V1, V2, V3, V4, and they definitely are getting smaller. All right. So we've looked at our QRSs now. Now what I do is I look at my T waves and my ST segments, okay? So first we'll do ST segments. I'm really looking down, and really if I look carefully, lead 2, you know, the ST segment is a little bit elevated here. So here's my J point, right where the S wave meets the T wave, right where it transitions. But if you look, It's really only bigger. It's like maybe 1 millimeter above. Okay. Remember, we have to be 2 millimeters above, and then it has to be 2 millimeters above in two contiguous leads. And I don't see that here. But here, Q, R, S, here's a T. So here's my J point. I compare the J point to my isoelectric line here. Maybe a millimeter, maybe not even a millimeter. Not worried about it at all. I can zoom out and I can do the same thing on all my other leads and really methodically look at everything. And I'm not seeing any ST segment elevation or any ST segment depressions. I then look at my T waves, right? How do my T waves look, right? They're all looking pretty good. I don't see any peaked T waves. These T waves look a little bit big, but they're not peaked, okay? I'll show you a lecture when we do, well, actually, we've kind of talked about hyperkalemia. I've showed you peak waves, T waves before. But peak T waves definitely don't look like this. They look like if you almost were to touch it, it'd hurt you, like it's like a needle. These are not peak T waves. They're all looking good. My T waves can be inverted in AVR. They can also sometimes be inverted in V1. So I'm not worried about that. Sometimes I get a little bit worried if I see flat T waves or if I see inverted T waves, because those could be signs of ischemia or subendocardial ischemia. And I'm not seeing anything here, okay? And then last thing we really need to do is we need to look at the QT interval, okay? So really a quick and dirty way to do the QT interval is I take one R wave to another R wave. That T wave, the end of the T wave where it gets back down to the isoelectric point should be less than half. I see it gets back down to the isoelectric point here, definitely within the half range. So my QT is not prolonged, okay? And then I think the last thing I forgot to mention was we can look at the axis of my EKG. There is definitely a more advanced way that I'd love to teach in its own lecture. But the quick and dirty way to look at the axis, I look at lead 1, and if it's pointing up, I put my left thumb up. I then look at lead 2. If that's pointing up, I put my other thumb up, my right thumb up. AVF can be used as a tiebreaker. It's also up. They're both pointing up. We're in normal axis. If lead 1 was up and lead 2 or AVF was down, I would put them like this, right? So lead 1 is up, lead 2 or AVF is down. I put them here and they're moving away from each other, right? So they have left each other. My thumbs have left each other. So that could be a sign of left axis deviation. Let's say lead 1 was down. I look at lead AVF next. AVF is up. They're coming right at each other. That's a sign of right axis deviation. I'll do a whole lecture on axis deviation coming up at some point in the near future. But that's how I read an EKG. This was a normal sinus rhythm. I'm at about 90 to 95 beats per minute. Then we look here. So this is going to be our Brugada. I'm not going to go through the whole thing. I do want to point out if we do our whole mechanism of kind of moving through methodically. And hey, take a screenshot. You have this lecture. You can go through this methodically and try to do everything I just did. But when I look here, looking at the forest and then the trees, normal, normal. Oops, that looks like a funny looking beat. Normal, funny looking beat. All right. These are what's called a premature ventricular complex. I will do a whole lecture on that. But basically, I see my QRS is very wide. It's much larger than 120 milliseconds. And then I see there's not a P wave before it. This is the preceding T wave. So that tells me that this beat is coming by itself from the ventricles, okay? But then I look up here, right? So this is my Brugada EKG just because I wanted to compare. Look at V1. Look at that nice little ST segment elevation here. And look at that steep decrease, right? That steep going down. That's definitely kind of keying me in. And then we have the inverted T wave. I see the same thing here. It's not as pronounced as that other EKG I showed you, but we see it here for sure in V1. V2 is definitely elevated, right? There's the ST segment or the T wave inversion. So the cove T waves, the cove T waves, T wave inversion, ST segment elevation in V1, V2. Even a little bit of V3 is kind of maybe not as much, but definitely V1, V2. This was taken from a 40-year-old man who came in with syncope, okay? So what do we do here? So Brugada syndrome, again, we're going to think about a younger male, often Asian, sudden syncopal or arrest, maybe afebrile or febrile, in an anterior STEMI or any kind of STEMI, older, chest pain, shortness of breath, the risk factors that we talked about. The ST segment elevation in Brugada is going to be V1 through V3 only. They're going to be coved or they're going to be that saddleback. Again, coved is what I'm looking for step 1, step 2. In anterior STEMI or any kind of STEMI, For anterior STEMI, it'd be V1 through V4. They'll often be convex or look like a tombstone. I'll show you that in a second. Or they'll be straight. And we might see reciprocal changes in some of the other leads like 2, 3 AVF. The QRS morphology, we'll often might see like a right bundle branch block like pattern in Brugada. And then in anterior STEMI, they may have Q waves or poor R wave progression. If we get the troponins, they'll be normal in Brugada because it's not ischemic. And then anterior STEMI, they'll be elevated. So remember, troponin gets released in some of my ischemic heart tissue. We'll talk about that later. So my key takeaway, if it looks like STEMI, but the patient has no chest pain, no risk factors, and the ST elevation is only V1 through V3 with a weird right bundle branch block-like pattern, think Brugada. If they have crushing chest pain, ST segment elevation in V1 through V4, plus reciprocal changes, it's probably a STEMI, all right? So that's kind of what I was talking about. So here's my Brugada, again, V1, V2, even a little bit in V3. Nice 45-degree angle. We have the inverted T wave. If I look at my ST segment elevation in these tombstoning, look at these like nice ST elevations. It looks like it's a legit tombstone, okay? Again, patient history is going to really help me out here. Refer back to this chart. So let's put it all together really quick, and then we'll be done. We have a 62-year-old man with a history of hokum and frequent PVCs. He's started on a new antiarrhythmic medication. 3 days later, he presents with tinnitus, blurry vision, headache, and nausea. He also reports feeling off balance and occasionally hearing a ringing sound in both ears. On exam, he's afebrile, normotensive, and oriented. There is no nystagmus or focal neurological deficit. Labs and head CT are unremarkable. Which of the following best explains this patient's symptoms? Is this idiosyncratic ototoxicity from amiodarone, anticholinergic toxicity from disopyramide, quinidine-induced synchonism, or reversible cerebellar toxicity from phenytoin, or salicylate toxicity from aspirin overdose? So pause your screen, think about it, and then we'll discuss. All right, so this is going to be I can't even say it, synchonism, okay? So it's a dose-related toxicity associated with quinidine and quinine, which includes tinnitus, headache, dizziness, visual disturbance, GI upset, okay? I want you to just really just jam this into your mind, okay? This shows up on STEP a lot. So synchonism, tinnitus, headache, dizziness, visual disturbances, GI upset after quinidine or quinine. It's a class 1 antiarrhythmic. It's a classic culprit, right? It blocks sodium and potassium channels. And in Brugada patients, it helps suppress the arrhythmias by blocking ETO current. So when I think about amiodarone, why were the wrong answers wrong? Amiodarone, it does not cause ototoxicity or tinnitus. Long-term effects are thyroid, lung, liver, right? We get TFTs, LFTs, and then PFTs before and during amiodarone treatment. Disopyramide can cause anticholinergic side effects, but it doesn't cause tinnitus or vision changes. Phenytoin, cerebellar toxicity causes ataxia and nystagmus, not tinnitus or visual issues. Aspirin can cause tinnitus, but it's usually with metabolic acidosis, hyperventilation, and toxicity signs, right? You'd have to take a crap ton of aspirin. None of that here. So again, synchonism, because we talked about quinidine throughout this lecture. Synchonism, very high yield side effect. Tinnitus, headache, dizziness, visual disturbance, GI upset, all right? So today we talked about Brugada syndrome. We talked about pathophys, management, how it presents differently from STEMI. We talked about how to read an EKG and look for normal sinus rhythm. We'll do much more of that as we keep going. We looked at EKGs of both STEMI and Brugada, and then we talked about synchonism for quinidine toxicity or just a side effect of quinidine. So please watch this multiple times, digest it. Let me know your thoughts. Reach out if you have questions, and let me know what other topics you want me to cover. Until next time.